Good evening to all the delegates. I welcome you on behalf of IMA Gujarat State Branch in today's first ever Doctors Protection League. Now the question is why the Doctors Protection League is required. As you know, the litigations against the doctors and hospital cares is increasing day by day. Our state's professional protection scheme also endorses that data. So there are which is the aspect to prevent such litigations. There are so many aspects, but most important is to knowledge of the law. So for that, IMA Gujarat State Branch has think to aware and to educate the medical fraternity about the law. And for that, last year, Gujarat State Branch IMA has started postgraduate diploma in medical law and ethics with the Gujarat National Law University, and the first batch, which was successfully completed, is postgraduate diploma, and the second batch is going on. This is unique educative programs of its own kind and first ever in the India. Now, I would like to invite our Gujarat State Branch President, Dr. Bharat Kakadia, for his welcome speech. Dr. Bharat Kakadia. Over to Dr. Bharat Kakadia.
Thank you, Dr. Kamlesh Shani Sahib. Good evening to all. After very sunny, hot, scorching heat day, it is little cool and calm evening. I welcome you all. And as Dr. Kamlesh said, it is a very, very unique legal point of view, our web seminar series. This is the very first. And I welcome our today's speaker, Dr. Gopal, Dr. Kruti, and Dr. Sanjay Bhatt. I am very much hopeful that this particular type of legal issues will be very helpful in our day-to-day practice, and it is a need of the time and need of the day. So without wasting much time, I would like to request Dr. Kamlesh for continue the program in a proper manner, and we have to justice our speaker, and we definitely enlighten with the knowledge of the legal issues. As our Rajkot IMA branch is having also one of the very important CME about the organ transplantations, I may leave the program in between. So please excuse me for that, but I hope and I wish all the success to this particular program and in the legal series of our future program. Thank you. Thank you very much.
Thank you, Dr. Bharat Kakadia, sir, for your blessings. Now, I would like to invite Dr. Brijesh Patel. He is a chairman of Hospital Board of India, Gujarat State Chapter. Dr. Brijesh Patel, over to you.
Thank you, Kamlesh sir. So good evening to all the doctors. I would like to say thank you to Team GSB and Team IMA to allow me to speak about the Hospital Board of India. The Hospital Board of India is an initiative of the Indian Medical Association, and it is one of the largest and most influential professional medical association in the country. So HBI is organization representing the healthcare providers in India. HBI main aim to improve the quality, accessibility, and affordability of healthcare service across the country. HBI serves as a platform for the hospitals, nursing homes, clinics, diagnostic centers, and other healthcare facility to collaborate, share best practice, and advocate for the interests of healthcare providers. So I would like to highlight some key functions and activities of the HBI. First important function is advocacy. So HBI for policy and regulation that supports the interest of healthcare providers and promote the delivery of quality healthcare service to all the segments of society. Second most important, quality improvement, then networking and collaboration, then policy engagement. Already we in last 2 to 3 months we met our health secretary regarding these policy issues. Then capacity building, because very important thing, HBI offers capacity building initiatives including training programs, workshops, skill development activities to strengthen the capability of healthcare professionals and institutions. And last most important functions is a research and publication, because we are lacking in this part. So HBI conduct research on the various aspects of healthcare. So friends, overall HBI play a vital role in advocating for the interest of healthcare providers and fostering collaborations, innovations to improve healthcare delivery. Small and medium-sized hospitals in Gujarat, like elsewhere, face a unique set of challenges, and due to their size, resources, limitations, and the location. So team, we are coming with many innovative programs for all healthcare providers. So thank you so much. Without wasting too much time, I request to Dr. Kamlesh Bhai, please continue our program.
Thank you, Dr. Brijesh Bhai, for giving the outline of the Hospital Board of India Gujarat State chapters. Now we move to our today's program. We have included the 3 topics. One is about the informed consent in the clinical practice. Second one is the law of POSH, and third one is the telemedicine guidelines into our day-to-day practice. So, and first topic is the informed consent in the practice. So friends, you might aware about what is the consent. In the general public, they take the signatures into the interventions program, interventions procedures, into the admissions, into the high case, high risk patients, or to the operations. They take a signatures. But friends, in front of the court, it is not valid. It is not a consent. They require a proper consent. So every practitioners, they should have the knowledge about the informed consents. And our Supreme Court have set the guidelines in the very famous and landmark case Samira Kohli versus the Prabha, the guidelines of the informed consents. So to discuss more about the informed consents, I would like to invite our first speakers, Dr. Gopal Shah. He is a very renowned neurosurgeon at KD hospitals. He also experts into the medical legal ethics. He has done his postgraduate diploma in medical law, policy and ethics from GNLU. He is an ex-associate consultant at Hinduja Hospital, Mumbai. He is a fellowship from Phoenix, USA, Australia, Trivandrum, London. So I would like to invite Dr. Gopal Shah. Over to Dr. Gopal Shah.
Thank you, Dr. Saini Saib. And good evening, delegates. I welcome you all on the first session of the first CME of Doctors Protection League. So I'll straight jump on the topic of consent in the medical practice. So, and we all three are the students of the first batch of GNLU, and just showing our gratitude towards the teachers at GNLU who have enlightened us with their knowledge. So I don't have any financial interest in the subject, and this is only for general information. I am not giving you any guidelines, or I'm not giving you any the base for creating your own consent process. So what is the importance of this topic? As we all know that, like every hospital, every clinic, every nursing home, when they start, the first thing comes to mind is the receipt book and then the consent form. So, but for us, the consent form is merely signing a paper, writing something, or having a blanket consent and getting it signed by the patient's relative. And that is our consent form. But we need to learn what exactly the consent is and what are the types of the consent. So safeguard individual autonomy of the patient and the family members, integrity of the noble profession. As we all know, we belong to one of the most noble profession on the earth, and it is our responsibility that we make sure we maintain the dignity of our profession. Obligation to the truthfulness and enhance the patient trust. In the current scenario, maximum number of violence against doctors probably are related to significant reduction in the trust issue between the patient and the clinician. So why the consent is necessary? So bottom line is consent is a legal requirement. It is not merely a procedure that we need to follow. It's a legal requirement in current era. It was always legal requirement, but when it was not much aware in the public, a lot of people used to get away without taking proper consent process. So it is for greater patient safety, higher ethical standards. The moment you start taking proper consent, the chances that we'll be conveying wrong information or any false hopes to the patient and the relatives will reduce significantly. We need to stick to the legal requirements to reduce the litigation. All that we are going to discuss today and in the upcoming sessions will be to reduce the litigation. So we are not teaching you how to fight the litigation. We are teaching you how to reduce the chances of litigation against us. And obviously, with more promotion of corporate, semi-corporate, and trust hospitals, the institutional quality and the reliability has to be maintained at a higher standard. And this is the beginning of the whole process. So to begin with, the consent is not just about a form. Like mostly when the patient comes to us, comes to a clinic for a procedure or a surgery or any intervention, he is handed over a form and is asked to sign on the bottom of the form without reading the things. And the fonts are also like those insurance company forms, where it is so much like jargons. It's so difficult to understand the things, and they just sign the form without understanding. So it's much more than signing a piece of paper without in-depth explanation. Now, MCI gave a ruling in 2002, which is more than 22 years back. They have categorically said that before performing the operation, the physician should obtain the consent in writing. There are other clauses related to the specific procedure, but this has been declared by the MCI in the Professional Conduct and Etiquette Ethics Regulation in 2002. So to start with the consent, it's a process of communication between physician and the patient that results in patient's authorization of agreement. So it's not about you sign this paper. It's a two-way communication. And when you sign a paper at the bottom, it is an agreement, and the agreement comes only when both the parties they agree to a particular point. So I am conveying some information to the patient and asking the patient to sign is a one-way process. So the consent has to be a two-way process. Giving all the details, making sure the patient and the family has understood all the details, and then getting it signed. If you don't take a proper consent, it will definitely end up in the medical legal lawsuits. Either it will be a civil lawsuit or a criminal lawsuit. The civil lawsuit will be will amount for compensation, and you can, as you might have read, it ends to few crores of compensation nowadays. And the criminal lawsuit may lead to imprisonment, which is very rare nowadays, but still not impossible. So you can see this is a beautiful sculpture, and I would say it's beautifully written, but nobody can understand it. So we don't want our consent forms to be beautifully written and described, but nobody can understand. And informed consent, what normally people have been telling, that I have explained everything to the patient relatives before surgery regarding the benefits and harms and risks. But as you can see in this slide, they don't understand. We have explained everything to them, but if they have not understood, then the consent process remains void. So it is not a valid consent. So what do you take home today? Is it a crash course for medical ethics? Is it a one-stop solution for all consent-related problems? Is it an ideal consent form that I am going to give you? The answer is no. This is going to be a knowledge sharing and knowledge-based learning, so that you can make your own consent form which suits your profession and obviously the understanding of the people living around you. The regulations which enforce the medical boards all around the world started long back in 1947, as you all know, after the Second World War. And then the WHO and all the medical boards, they decided that no procedure should be done on any patient without taking the proper consent. And then so on, it has become an international issue since then. So what are the two consent process, basic consent process? One is a patient prudent and one is a physician prudent. Or I would say physician prudent consent is normally practiced in UK, and earlier it was practiced in US, where The doctor says that you have to undergo this procedure, and if the patient wants to ask some questions, then patient would ask the question. Otherwise, it is considered, or it is assumed, that whatever the knowledge patient has is sufficient enough to sign the consent. While we need to follow the patient prudent consent process, where patient is supposed to be given all possible information, including brochure, verbal, written, audio, visual, or the surgical videos, share the details, give all explanations, and give them enough time to understand and reply, and then question the things. That is a patient prudent consent, and we need to follow patient prudent consent as much as possible so that we can avoid legal issues in our clinical practice, which will take a lot of time and money. So we say it's an informed consent, but informed consent is not fully informed unless it has been properly conveyed to the family. Just signing the paper, this sentence will come probably 5 times in our lecture, so that you remember it, that getting the paper signed by the patient or relative does not mean it is an informed consent. And the consent that we normally tell, that ask for a medical officers or a nurse, that you take the consent. The consent has not to be taken by the doctor. The doctor has to administer the consent, and the paper is signed by the patient or relative. So consent is not given, it is administered. So what are legal perspectives that we need to understand before undertaking a procedure or a surgery, or before undertaking a consent? There are four basic things. One is the beneficence. We need to understand that there has to be a maximum benefit to the patient before starting treatment and minimize harm. Second is a non-maleficence, which is popularly known as primum non nocere, where the clinician should not have any malefied intentions in treatment of the patient. I would not go in more detail of that. Third is the autonomy. Autonomy is the patient's autonomy. Patient who is adult, patient who is into normal full senses, should be given his autonomy to decide whether patient wants to undergo a procedure or not. And fourth is a justice. The treatment should be equal for every citizen of India. So that is a justice. You don't customize treatment based on patient's different age group or creed or a financial status. So the consent is a teamwork. It's not like a doctor taking consent or a medical officer taking. It's a teamwork. A primary clinician or the chief doctor would talk to the patient. They give details to the patient. Then it is to be written by a medical officer. It is to be explained by a nurse, and then it is to be signed by the patient and the family members, and preferably in front of a clinician. So it's a team process. Don't give the burden of consent just to a nurse or a medical officer. Again, it's a dynamic process. Like a patient coming to you giving consent for a particular thing doesn't mean that patient has consented or patient has surrendered himself or herself, completely putting faith in you. It is a dynamic process. As we go on in the part of the treatment, we have to keep updating our consent. It is not necessarily written or recorded. Like we have reached to an era where verbal consent or a written consent. Now we have reached to an era of audiovisual consent. But we need to understand, whatever amount of consent you take, whether it is audiovisual, it is imperfect or invalid unless it is properly conveyed. So the major components are mindfulness and understanding. So what is mindfulness? The patient who is signing the consent or the relative who is signing the consent has to be mindful. He should understand the things appropriately, and he should reciprocate properly after understanding the consent, that he is following whatever the consultant has told. And the second is a no undue influence or coercion. No consent should be taken under pressure. So consenting is for proper communication. And the third point is very, very important. It's a myth that consent, I have taken consent, so I'm safe. Consent doesn't make physician immune to litigation, but it shifts the burden to the patient. If you have taken a proper consent, proper written consent, explained consent, informed consent, the patient has to prove that the communication was inadequate from the doctor side. Because once patient signs a consent, they are answerable. If we don't take consent, we don't have any defense weapons with us. But once we have taken an appropriate consent, it gives little defense to us. and the patient and the relative have to prove that the communication was not appropriate. Just to share a slide during our GNLU sessions, it's just lighter moments, and in the middle we can see our beloved Dhanya ma'am, who is the whole program was her brainchild, and she executed the program very well. Now, the types of consent. We all know about only one consent, that we have done paperwork, we have got the patient's consent, we have done the relative's consent, the witness consent. But there are different types of consent, and we need to understand all of them before we go into the clinical practice tomorrow morning. One is the implied consent. So what is implied consent? When the patient comes to a clinic, he enters the clinic. So it is implied that patient has given you consent, or patient has given you authority to talk to him, to take his history, to take the details, to check the reports and examine the patient. So this is an implied consent, which doesn't need any paperwork, which doesn't need any explanation. It's an implied thing that patient has come to you, patient has issued a OPD paper in your clinic. So it is implied that patient has come to you with some trust. Second is the express consent. After the patient comes to a clinic and after certain conversation, you need to examine the patient. Then you have to express that I am going to do the neurological examination, I am going to stretch your soul, I am going to apply hammer in the joints, or I'm going to put a stethoscope in the chest or abdomen. So there is an express consent. If the patient refuses, then we cannot go ahead. So that's a type of consent where it is not just gesture, but you have to tell the patient that I'm going to do this thing. Third is the informed consent that we have been discussing since last 7 minutes. Fourth is a surrogate consent. The surrogate consent is when the patient is not fully conscious, patient's IQ level is low, then either the patient has given consent earlier, or the family members are giving consent, or the treating team members are staying there as a witness for consenting. That is a surrogate consent. And an opt-out consent. So opt-out consent, nobody knows in our clinical practice. The patient is right to choose at what stage he wants to opt out of the treatment, and that is also a very important part of our consenting process. So implied consent is obviously the patient entering the consulting room and submitting himself or herself to a clinical examination is an implied consent. Express consent, as I told you, for intimate examination, per vaginal or per rectal examination, if it's drawing some body fluids, then it is preferably having a written consent. And as you can see, the expressed written consent is most indisputable form of consent. Express it and write it. Surrogate consent we already discussed, and it won't be of much clinical importance in day-to-day clinical practice. Now, the point comes that I've explained you all these type of consent. So which is better in what position? So the clinically important thing is when you are doing a routine treatment, implied consent would suffice. Patients in a medical OPD or a general physician's OPD, the implied consent is sufficient. Express consent is better. I'm going to do this, I'm going to do this, I'm going to examine, I'm going to check your pressure. It is just a communication with the patient which will definitely enhance the trust in you. When you're doing the detailed treatment, obviously express consent is necessary, but to write is safe. And when you're doing a complex treatment, some major surgery or some diagnostic procedures, written and informed consent. So different consent procedures, different stage of treatment. And that is what I told you, that the consenting is a dynamic process. High risk consent is a separate topic. I'll just give you a brief at the end of the lecture today. So informed consent is necessary for any of the procedures, like any invasive procedure. So any cuts, any wounds, any needles going in, any scalpels, informed consent is necessary. Like patient undergoing chemotherapy or radiation therapy. In radiation therapy, there is no cuts, no wounds, but it is an invasive procedure. The consent is necessary. Any body tissue invasion, you are doing the endoscopy, you are doing bronchoscopy, you are doing lumbar puncture, consent is necessary. Injection of dye, you are doing a contrast examination in CT scan or MRI, and there is a likelihood that patient might get complication because of the dye, so consent is necessary. Most of the vaccines, consent is necessary. Nobody does, but it is necessary. Blood test like HIV. HIV is ideally the HIV needs a consent before sampling the patient's blood for HIV. So all of these procedures, informed consent. It is not only implied consent or express consent, informed consent. It has to be an informed consent before you do any of these things. And if we fail to do this, we should be ready to face some litigations. So what should be there in the consent? We know that we need to take consent. So what should be there in the consent? It should have the primary diagnosis. If we don't have the diagnosis, then the provisional diagnosis. Then what type of treatment patient is going to be offered by you? What are the risks of the treatment? What are the benefits of the treatment? Now, this third point is very tricky. Many times, being clinicians in a competitive field, we are afraid of losing the patient if we explain the risk too much. But it's a rat race, so don't do that. Whatever the risk which has been written in the literature, which you have learned during the conferences, plus your own data of risk and complication, you have to explain to the patient, and it has to be a part of the routine consent process. I spoke to many of my colleagues, and they say that if we say that patient may die during the surgery of appendix or hernia or orthopedic surgery, then patient may go to some other consultant. Then feel free, let them go. When all the clinicians start giving this risk statistics to the patient, the chances that litigations or the violence against doctors will definitely reduce, because they should not feel they are being cheated. Patients should be aware about the alternative treatments. The common problem is, I am good at this particular type of surgery, and patients should not know that other treatment modalities are available in our city, our state, or our country. Whatever treatment is available currently in the medical science, patient has to be aware about it. I'm not talking about the lumbar puncture or the bronchoscopies, but when you are doing a major invasive procedure, patient must be aware about all those facilities or treatment options available, regardless of cost and availability. Like, cost is not a prohibiting factor of explaining. Let the patient decide what treatment they want to go based on the availability as the costing. You don't dictate him that at this cost I will do this treatment, right? The risk and benefit of alternative treatment and probable outcome. Like, we also need to tell the patient in a simple language without producing a sense of fear or sense of threat that probable outcome is going to be bad if you don't take this treatment. To discuss the financial things is debatable, but still it is always better to be clear about the financial things before we start treating the patient. The consent has to be disease specific. Like, there should not be a blanket consent that one consent form that has been copied from one hospital to other hospital, one clinic to other clinic, and it keeps on running. It has to be a disease specific. If you are treating a patient of cerebral malaria, you should have a consent form based on your experience and the available data. And it has to be signed by that. If you are doing a brain tumor surgery, it has to be a specific consent form for that. If you're doing a femur fracture surgery, you need to have consent or a procedure specific form. It has to be simple, no jargons, no medical jargons, no complex medical terminology just to show off our knowledge. It has to be simple form in a vernacular language. A Rajasthan patient signing a Gujarati consent form, a South Indian patient signing a Hindi consent form has no validity. It will not give you any protection in the court of law. After giving the information, we need to give appropriate time for the patient and the family to understand and reply to the consent process. You don't force them to give consent straight away. Competence and capacity, as I told, the patient has to be conscious, understanding, and adult. Consent paper has to be signed by patient or a legal guardian. Legal guardian is where the patient is a minor. The legal guardian would come in action. The last point is little debatable in our system, because it has to be signed in presence of two witnesses when you are undergoing a major surgical procedure, and those witnesses need not be a part of the discussion. The witnesses are needed just to confirm that the patient has signed the consent without any coercion. So witnesses do not need to know what the discussion has gone between the consultant and the patient. A big thanks to Dr. Mehul Shah, who has been so inspiring since beginning. And again, this whole program, session is the brainchild of him. So big thanks to him. Now, what is free consent? So you need to remember all 8 points that I've written here, and without a fail, you have to follow it religiously every time you see a patient. So it should be force-free. You don't force the patient to consent. Give information and ask the patient to decide and reply. It should be fraud-free. You don't do emotional blackmailing of the patient to consent the paper. It should be deceit-free. You don't make you don't create any confusions. Make it very clear each and every point when you consent the patient. It should be coercion-free. No pressure, no force, no emotional blackmailing that if you don't get operated, if you don't give consent, this will happen, that will happen. Let it be very free. It should be constraint-free. No constraint should be there when patient is signing the consent form. Sixth point, very important, let the patient go away from your clinic if it doesn't agree to your consent process. When you explain the complications, risk, and the patient's relatives are not happy to hear that, it means he is not a right patient to treat. So if the patient wants to leave the clinic understanding that procedure is risky, let them go. Don't force them to get treated by you. And right to choose alternative treatment. You give your options. If I'm doing particular type of surgery at my hospital, but there is a better alternative available which is not available in my hospital, then I need to give them options. I need to give them options if they're available outside Gujarat even. But the patient and the family has to be aware about the available options. And the last one is right to recall. The patient has all rights to recall or withdraw the consent so that the treatment has to be stopped the moment patient says. Obviously, we need to consider the scientific parameters at that time. These are the few case studies. Maybe we'll share the PPT and you can go through the case studies. These are related to different consent-related issues, which led to major litigations against doctors, and they were all penalized. Now, this is something little time-consuming and boring for most of the clinicians who are running busy clinics. Documentation of the consent. You might have a assistant to do all these things. Date of the consent, time of the consent, persons who were consented, like what family members were there, what is the relation to the patient, what information you provided, whether it was verbal information, paper, written, drawings, audio, visual, your surgical videos, the pictures, whatever. What time, how much time did you take for discussion, and how much time did you give the family to decide? I have given information, immediately you have to make decision and consent for surgery. That is wrong. Give them few minutes based on the seriousness of the issue as well as the emergency situation. And what question answer were there from patient's mind that you cleared, that has to be mentioned in the consenting and the signature. Now, these things will save you. Only signing the paper will not save you, because the moment they feel they have been betrayed, they've been backstabbed, they will do all the efforts to file a suit against you and they will win. Now, what are the invalid consents? This need to understand that consenting is a mutual thing. It's an agreement. It's not an order. So it has to be we rather than I. A blanket consent format, which is there in 99% of the hospitals currently, is invalid. A pre-printed consent form where you write patient's name, type of surgery, complication is invalid. It has to be disease-specific, procedure-specific consent form. A surgery and anesthesia consent form combined is invalid. It has no value in the court of law. The same consent form for repeat procedure. You have done a laparoscopic procedure for a patient, and the next patient needs resurgery. I have done a craniotomy, tumor excision. Next patient needs re-exploration. It has to be reconsented. The same consent form is invalid. Unilaterally executed, like I type of consent forms, are absolutely invalid. And consenting for illegal procedure, like if you're doing an MTP, sorry, but if you're doing an MTP in a minor child, which is anyway illegal procedure, even if you take a detailed consent, it is illegal. It has no validity. Now, when the consent is not needed, this is also very important. Therapeutic privilege. Sometimes a patient has to undergo a major surgical procedure which has got very high implication, high mortality, high morbidity. Then you might suppress certain information from the patient rather than giving all information, so that the patient doesn't undergo major psychological trauma. But that has to be mentioned in the record that this information has been hidden from the patient and it has been discussed with the other family members. Advanced directive, we'll have a lecture on advanced directive, so I will not go into detail of that. And consent for minors. Now, again, it's a myth that minors, like kids, don't need to understand anything. In today's world, if you see, I treat a lot of kids at age of 14, 15, 16, they have so many intelligent questions. We need to answer them. So below the age of 12 years, child cannot sign consent. It has to be signed by the local guardian or the parents. 12 to 18, you can consent if they are sufficiently understanding. If you've got a patient of 15 years old and he knows everything about the disease, he asks you questions, then he can sign the consent. And when the case goes for litigation, the child's level of understanding will tell us whether you are going to win the case or not. Now, the last point is, when you operate a child, when you treat a child, the papers have to be maintained till the child grows to 21, because if the child grows to 21, you operate a child at the age of 10 years of age. After 11 years, he can sue you. So you need to be ready for those. When the child was operated, the consent was given by the parents. But when he turns 21, he can raise his sword against you. Now, these are the cases where you don't need consent. So consent. Don't delay the patient treatment just for consent. It's a life-saving emergency procedure or an additional emergency surgery. You are doing some surgery. During surgery, you find that we need to do some extra procedure to save patient's life. You don't need extra consent. You might just inform the family waiting outside. And the court has ordered some treatment for a prisoner or a rape victim. Mandatory vaccines, you don't need consent. Like DPT vaccine, you don't need consent. Quarantining epidemics, you don't need consent to treat those patients or quarantine those patients. Patient with a severe mental health condition or severely ill or unhygienic living condition, those patients can be forcefully treated in the government hospitals. Now, coming to the nearly end of the presentation, audio video consent is very popular nowadays. Like everybody is saying that I have put a CCTV in my audio video recording in my consulting room. It is good for your safety. But remember one thing, you need a consent of the patient and relative if you want an audio video consent, so that they should be aware that you are recording. If the patient comes to know that you have recorded the things without their knowledge, the game is over. It's not mandatory, but it helps. And this will, if the patient and the family knows that they have consented audio-visual setup, it is less likely to be hostile. But you need to understand that display in the consulting room that you are under CCTV surveillance. Your consulting room is a private premises, and you cannot have a CCTV surveillance without displaying the banner. There's a fashion of not telling the adult patient about the treatment or surgery because of fear of psychological trauma. It is wrong. An adult patient, an adult competent patient has to sign the consent form, not the relative. Patient who is adult and competent has to sign the consent. So, just a few pearls of wisdom. Build trust before legal formalities. There is no optimum information. You have to decide based on your knowledge about the subject, your experience about the subject, and patient's keenness about knowing the information. So there is no optimum information. If you furnish every information, they'll get confused. If you don't furnish any information, you will be in trouble. Don't skip major risk. It is possible that in emergency you might not be able to explain everything, but don't skip major risk. Explain major risk. You may not explain minor problems, but major risk you have to explain, not just because of the fear of losing a case. Explain difference between risk and complication. There are certain problems like major surgery. There are certain inevitable problems which is part and parcel of the surgery. It is risk. Complication is something which is untoward, which is unexpected, and which may cause a morbidity. It is complication. I'll skip this. This is a picture of our completion of the course. The director of GNLU and our beloved Gopal Shah sir. So final slide, a medical practice is a noble profession, as we all know. And the honest communication, it's just remember the thing, honest communication. It's not information providing, it's a honest communication between the two contracting parties is the foundation of the trust. Unless there is a trust between the doctor and the patient, you're likely to end up in a trouble. Remember one thing, a valid consent is not licensed to dash dash dash. You need to understand that very well. It is not only ethical to impact correct and necessary information. So it is a correct and necessary information to a patient prior to conducting any medical procedures, but it is legally required. It's not only ethical part, it's a legal required. Take your time, but do it right way. Don't take it easy. Proper consent can save you. And self-written consent by the patient is least likely to be challenged. So I've learned it from a few of our senior doctors. If the patient is absolutely understanding, ask the patient to write the things. It is not immunity, it is extra defense. So in my opinion, laying down rigid criteria is difficult from both sides, from society side and the medical council side, but it has to be an optimum criteria for consenting. And increasing the burden of proof on the clinician, like doctors, will eventually increase the risk of the treatment cost, the duration of the treatment, as well as the economic burden on the society. So we need to balance between the extra cost versus proper treatment. And the last point is, more risk involved, rigorous should be the informed consent. If you're doing a high risk treatment, meet the family in the morning, meet the family in the evening, have a family meeting, explain everything, have second meeting before surgery, third meeting before surgery, and then do the surgery. Having furnished all the information, it is least likely that they will have distrust in you, or they will feel cheated, or they will litigate you. Thank you very much. We'll take the questions at the end.
Thank you, Dr. Gopal Shah, for touch upon the every details of a very complicated topics or informed consents in a very simple way. As I said in the beginning, it's a most neglected part. The consent is the most neglected part in our day-to-day practice. They take the simple signatures and they say they feel that they are the safes in the court of the law, but it's not like that. And you explained very nicely in details what is the importance of the informed consents.
Thank you, sir. Thank you very much.
Our next speaker is Dr. Kruti Deliwala. He is an associate professor of gynecology at Srimati NHL Municipal Medical College, SVP Hospital, Ellisbridge. And her topic is prevention of sexual harassment of workplace. So over to you, Dr. Kruti.
A very good evening to all my respected seniors, colleagues, and friends. I must congratulate our prestigious IMA and its Gujarat chapter and their office bearers for initiating this Doctors Protection League need of today's era. At this juncture, I am very much grateful and feel privileged to be a part of this online CME. I would also like to extend my gratitude to GNLU Gandhinagar for awarding me the postgraduate diploma in medical law and ethics. These are some memories of the GNLU. Next. You have to come. Sorry, 2 minutes. You have to come here. Hello. Yeah, please share. Yeah, now you can share. I have stopped from my side. Next. These are some sweet memories of the GNLU. We have taught so many things by our teachers, and that has clarified our ideas in a very good way. My previous speaker, Dr. Gopal Bhai, opened this inning by excellent presentation on the consent. And now I am going to start my batting with the most important but somewhat less discussed topic on the POSH. Next. As you all know, a safe workplace is the women's legal right. Sexual harassment constitutes gross violation of the women's right to the equality and dignity. It has its root in the perception of the man. They are always feel that they are superior to the women, and some form of the violence against the women are always acceptable in the mind of man. Workplace sexual harassment is not harmless. It involves serious health, human, economic, and social cost, which manifest themselves in the overall development indices of the nation. The women, they do not report the matter to the concerned authorities in most of the cases due to the fear of the reprisal from the harasser, being stigmatized, or losing the professional standing and personal reputation. Next. Workplace sexual harassment, it's a form of the gender discrimination which violates the women's fundamental right to the equality, right to life guaranteed under the Article 14, 15, and 21 of the Constitution of India. Harassment of the women at the workplace, that is Prevention, Prohibition, and Redressal Act, was enacted by the Ministry of the Women and Child Development in India in 2013. The POSH Act has been enacted with the objective of preventing and protecting the women against the workplace sexual harassment and to ensure the effective redressal of the complaints of the sexual harassment. Next. So, how the POSH has evaluated? The workplace sexual harassment in India was for the very first time talked after the recognition of the Vishakha judgment. What is the Vishakha judgment? In this case, Bhauri Devi, she was a social worker in the Rajasthan, was working against the child marriages. She has prevented the marriage of the 1-year-old child. This was not liked by the society, and she was gang raped by the man of the society. So appeal was, that is the public interest litigation, was filed in the Supreme Court, and the Supreme Court has given the judgment, and that is well known as the Vishakha judgment. The Supreme Court has framed certain guidelines and issued the directions to the Union of India to enact the appropriate law for combating the workplace sexual harassment. But nothing less of an irony, POSH Act and POSH rules was enacted after 16 years of the Vishakha judgment. Next. So as per the Vishakha judgment, any unwelcome sexual determined behavior, that is the physical contact and advances, a demand or the request for the sexual favors, sexually colored remarks, showing pornography, any other unwelcome social, verbal or unverbal conduct of the sexual nature, all these will be considered as a sexual harassment. Next. So, according to the late Chief Justice J.S. Verma, the meaning and content of the fundamental rights guaranteed in the Constitution of India are of sufficient amplitudes to encompass all the facets of gender equality. Next. So, how the POSH Act and POSH rule has been evaluated. In 2007, the draft Protection of the Women Against the Sexual Harassment Bill was approved by the Union Cabinet. Then the bill was introduced in the Lok Sabha once and twice. Then it should be passed by the Rajya Sabha. And then the act was revised by the President's assent in the year 2013. So the POSH Act and POSH rule came in the December 9, 2013. Next. So these are the acceptability and the scope of the POSH Act. The aggrieved women, who is the aggrieved woman? The woman who is working either on the domestic worker, regular or temporary basis, ad hoc basis, either she was paid worker or the voluntary worker, employed directly by the employer, or she is a part of an agency. All these are the aggrieved women. if the woman is doing the is harassed sexually while visiting a workplace, then also she is liable to consider under the POSH Act. And the student, if any sexual harassment done with the students while doing in the colleges or the schools, then also the POSH Act will be identified. Next. So what amounts to the sexual harassment? What are the types of the sexual harassment or the inappropriate behavior? There are two types of the sexual harassment. One is the quid pro quo, means this for that. If you do this, I will give you this. Implied or explicit promise of preference in the treatment in the employment. Sometimes implied or expressed that about the present or the future employment. Then it is known as the quid pro quo type of the sexual harassment. And sometimes by creating the hostile work environment, intimidating or offensive work environment, then it is also considered as a sexual harassment. Humiliating treatment, if it is given to the female, or sometimes some verbal or any kind of harassment is given, then it is the hostile work environment. Next. So what do you mean by employee? As I have already said, if the employee is regular, temporary, ad hoc, any individual who is doing the daily wages, the worker who comes to our place for the daily work, then also this act will be applied. And then it is also applied to the contract laborer, co-workers, probationers, trainees, apprentice, with or without the knowledge of the principal employer, whether the remuneration is given or not, or it is directly appointed by the employer or by the any other person, this act will be implied. Next. What next? What do you mean by workplace? Workplace includes any place which is visited by the employee arising out of during the course of the employment, including the transportation provided by the employer for the purpose of commuting to and from the place of employment. If sometimes the official visit is done by the women during the course of her job, then also it is to be considered as a workplace. And a safe workplace is the every woman's right. Next. Complaint committees. The POSH Act requires the employer to set up the internal committee at each office or the branch or of an organization employing 10 or more employees to hear and redress the grievances pertaining to the sexual harassment. And failure to constitute the IC lead to the imposition of a fine under the POSH Act. Now, how we could constitute the IC? In this, the presiding officer should be a senior woman employed in the institute. The members, not less than 2 members from the employees, and there must be some other external members from the NGOs or association committee who has the knowledge of the law, or they will either they are working as a social workers. Not less than of the half members should be a woman. The term of the IC committee is of the 3 years. It should not be more than 3 years. And minimum of the 3 members should be present while conducting the inquiry. It includes the presiding officers also. Next. There are some practical tips for constitution of the IC. It should comprising of the women members who have already trained in the POSH Act and POSH rules. The odd numbers of members should be there in the committee so that we can arrive at some decision. If the equal number of members are there, then it is difficult sometimes to arrive at the decision. They should be selected on the evaluation of the various factors. They should be accessible, approachable, committed, sensitive, and understandable. They should be sensitive to understand the pertaining issues regarding the gender bias violence. They have the good credibility among the staff. Technical competency should also be there. The functioning of the IC should be autonomous, and there is no scope of the allegation of the bias or favorism. The IC should provide the separate space in the office for their meetings and maintaining of the records. Periodic discussion between the IC members should be done to conduct the regular training of the staff also regarding the POSH Act and POSH rules. Next. Next, regarding the local committee, in certain companies where the employees are less than 10, or sometimes in the district level, the government is also required to set up the local committee to investigate and redressal the complaint of the sexual harassment from the unrecognized center. Next. How we can constitute the LC. In the LC also, the chairperson should be the eminent women in the field of the social work. The local women, any one of the members should be nominated from the taluka, block or municipality in the district. 2 NGO members should be included. At least one should be the women and the other should be familiar to the POSH Act and POSH rules. 1 member should have a background in the law and 1 woman should belong to the scheduled caste or scheduled tribe should be included in the LC. Next. What are the powers? The POSH Act stipulates the internal committee and the local committee with the powers as vested in the civil court under the Code of the Civil Procedure. In respect of summoning and enforcing the attainment of the any person, examining on the oath, requiring the discovery and production of the documents, any other matter. So they should be given powers as of the civil court. Next. What is the complaint mechanism? If the aggrieved woman who intends to file a complaint should require to submit the 6 copy of the written complaint with the supporting documents, the name and address of the witnesses, and all these should be submitted within 3 months from the date of the incident. And if there are series of incidents, then they should be submitted within the 3 months of the last incident. Next. A well-drafted complaint should always address to the IC members, not to the employer. It should be concise, well-written, presented properly. It has the good credibility. It should include the details of the exact incident, date, time, and witnesses. The circumstances preceding and following the incident should also be recorded, and whether the complainant ask the respondent to desist from the unwelcome act or not, it should also include. And they should the complaint should be supported with as many as documents if possible. That is the relevant emails, screenshot, SMS, WhatsApp messages, call details, photographs, etc. should be submitted if it is there. The details of the respondent, including name, designation, reporting structure between the complainant and the respondent, should also be submitted. And any false or incorrect statement or the things should not be submitted to the IC committee. Next. So these are the do's and don'ts for the complaint committee. The complaint committee should create an environment which is friendly. The body language that of the communication should be in form of complete attention. They have to treat the complainant with the respect, discard the predetermined ideas in the mind, and determine the harm. And the members of the IC committee, they should not get aggressive. They should not insist on a graphical description of the sexual harassment. Do not interrupt the complainant in between. Discuss the complaint in the presence of the complainant or the respondent. Next. Before initiating the action on the complaint, the IC on the request of the aggrieved woman can make effort to settle the matter in between the parties, like settlement outside of the court. It is possible in these kind of the cases also. Conciliation is possible before starting of all the procedures, and it is the informal method of resolving the matter. And once the settlement is done, the IC shall record the settlement arrived at and thereafter provide the copies of the settlement to both the parties. And once the settlement is arrived, no procedure of the inquiry should be done. Next. What are the timelines for all these things? So written complaint with the supporting documents and everything should be submitted by the aggrieved woman within the 3 months of the incident, as I have already said. And if there are multiple incidents, then within the 3 months of the last incident. Now, after recipient of the complaint, the 1 copy of the complaint is to be sent to the respondent within a week by the IC committee members. Upon the receipt of the complaint, the respondent is required to reply within the 10 working days. for his supportory documents, name and addresses of the witness, everything. Then the inquiry should be completed within working 90 days from the receipt of the complaint by the IC committee. And the report should be submitted within 10 days after the completion of the inquiry. Now, the role of employer claims is required to act on the recommendation of the IC within 60 days of the report of the receipt of the inquiry report. And now, if the respondent, he is not agree, then he is allowed within 90 days from the date of the recommendation. So these are the timelines. We have to follow this timeline, and everything should be completed within this time frame. Next. What is the interim relief? While all these things happens, during this time, the aggrieved woman should be transferred to the other workplace, or sometimes the respondent is transferred. The women should grant the leave apart from her routine leaves. Sometimes respondent is restrained from reporting the work performance of the aggrieved woman. All the data of the women should be transferred to the other person if he is the senior officer to her. Next. What are the punishment and compensation? The POSH Act also prescribed the punishment to the employer for indulging the act of the sexual harassment. Usually the punishment is prescribed by the organization itself. In the rules of the organization, they have to decide the punishment. But if the punishment is not decided, then they can decide whether according to the guidance of the IC committee, disciplinary action should be taken with the written apology, warning is given, sometimes withholding the promotion, withholding the pay rising, or termination of the respondent from the service if he has done major things. Sometimes counseling sessions should also be given if psychiatric problem is there. And deduction or the compensation payable to the aggrieved woman from the wages of the respondent should also be sometime given punishment in that form also. Next. So the POSH Act also envisages the payment of the compensation to the aggrieved woman. As I have already said, all these things, they are paid for the mental trauma, pain, suffering and emotional distress, lose of the career opportunity, sometimes medical expenses that incurred by the victim for the physical and psychiatric treatment, income and status of the alleged perpetrator, and feasibility of such a payment is done either in the lump sum or the installment. Next. POSH Act specifies that the information pertaining to the workplace sexual harassment shall not be the subject to the provision of the right to information. It should not be disclosed to anyone according to this act. It also prohibits the dissemination of the contents of the complaint, the identity and of the address of the complainant, respondent, witnesses, any information relating to the conciliation or the inquiry proceedings, recommendation of the LCIC, or the action taken to the public, press or media. So the matter should be kept confidentiality and it should not go out of the IC committee. Next. So what are the consequences of the non-compliance? If the employer fails to constitute the IC and does not comply with the requirement prescribed under the POSH Act, a monetary penalty of up to 50,000 INR may be imposed. A repetition of the same offense could result in the punishment being doubled and or deregistration of the entity or revocation of the statutory business licenses can also be done. It is also pertinent to note that all the offenses under the POSH Act are non-cognizable. Next. Thank you so much.
Thank you, Dr. Kruti, for explaining the POSH Act in details and what is the importance of the POSH Act in our healthcare establishment. You also explained in details about the ICC, local committee, complaint mechanism, reconciliations, punishment and compensation, and all other aspects of the POSH Act. It was very nicely explained. Thank you, Dr. Kruti. Now, for our next speakers, Dr. Sanjay Bhatt. He will talk about the telemedicine guidelines in the practice. Dr. Sanjay Bhatt is MD Medicines, practicing for more than 27 years in Rajkot. He has a PG diploma, medical law in policy, ethics, and at GNLU Gandhinagar. He is a past president of IMA Rajkot. Over to you, Dr. Sanjay Bhatt.
Good evening, everyone, respected seniors and dear friends. Because of paucity of time, I will straight away start the topic. Can I have my slides, please? Today we are going to discuss about telemedicine practice guidelines. Next slide, please. In India, providing in-person healthcare is challenging, especially in remote areas with limited resources. Rural patients have to travel long distance for healthcare. In such scenario, telemedicine provides timely and fast access to healthcare, and also it reduces the cost of travel and inconvenience to families. We have seen good utility of this telemedicine during COVID times. Next one. The government is committed to providing equal access to quality care to all, and National Digital Health Mission is a crucial enabler for overall transformation of the health system. However, there has been a concern on the practice of telemedicine. Lack of clear guidelines has created a significant ambiguity for practitioners. After a long discussion, ultimately, Ministry of Health and Family Welfare, along with Niti Aayog, came out with telemedicine practice guidelines in 2020. Next. What this definition is very complex, but this is what is defined in law. Telemedicine is the delivery of healthcare services, where distance is a critical factor, by all healthcare professionals using information and technologies for the purpose of valid information for diagnosis, treatment, and prevention of diseases and injuries, research and evaluation, and continuing education of healthcare workers with the aim of advancing health of the individuals and communities. Next. Registered medical practitioner is what? It is I am a member registered under State Medical Register or Indian Medical Register under Indian Medical Council Act 1956. Next. These two are important terms. What are the purposes and advantages of having a telemedicine practices? Because it gives access to healthcare in remote areas. It is cost effective. It reduces burden on the secondary hospitals. If primary patients are treated on telemedicine setup, then less patient will go to secondary care hospitals. Every details are documented. So chances of missing out doctors' advices are very less. There's a written documentation. So written documentation increases the legal protection of both the parties. The transmission of infection is less likely, especially in pandemic like COVID, both for medical persons and patients. Wearable medical devices are available now, which are helpful for remote monitoring of the patients. So in future, with the help of artificial intelligence and newer devices, telemedicine will be more useful. Next. Now, telemedicine can be classified on various ways. One way is that what is the mode of communications? There are three basic modes: video, audio, and text-based. For video, you can use any chat platform, Skype, FaceTime, WhatsApp call. For audio, you can use phone, apps. For text, you can use text messages, website, general messages, WhatsApp messages, and other chat platforms. Even text-based messages can be done through emails and fax. Now, this can be a real-time conversation, or both the parties can send information as per their convenient time. Patient sends reports and investigations and histories to clinician, and clinician sees those investigations at this convenient time and then revert back. So both the way it is possible. It can be real time also. It can be at convenient time also. Next. Telemedicine can also be classified on the basis of consultation. There are two types of basic consultation: first consultation and follow-up consultation. What do you mean by first consultation? Patient consulting to a doctor for the very first time. That is first consultation. Patient has consulted doctor before, but there is a lapse of more than 6 months. Then also is the first consultation. If patient has consulted a doctor within less than 6 months, but wants consultation for different health condition or a new disease or a new symptom, then also it is a first consultation. right? The follow-up consultation means patient is consulting with the same RMP within 6 months of his or her previous in-person or online consultation, and this is for the continuation of care of the same health condition. So these are the two different types of consultations as far as telemedicine is concerned, and both the types of consultations are on non-emergency basis. Next, telemedicine services should be avoided for emergency care, where alternative in-person care is available, and to be practiced only when in-person emergency care is not available. Telemedicine can be practiced in emergency, but it should be limited to first aid, counseling of the patient, and proper referral advice. Next. Now, telemedicine can be classified based on who is doing communications. There are 4 subsets. Patient can directly do consultation with doctor. A caregiver, a patient is having stroke or incapacitated or aphasic, he cannot speak, then caregiver can do consultation on behalf of patient to doctor. Healthcare worker, like staff nurse, can consult a doctor, and even a doctor who has come on the visit to see the patient, he can also consult another specialist or a super specialist. Next. So there are certain practice guidelines. How to practice? By and large, the combination of staff nurse or a RMP consulting another specialist or super specialist, it is a good combination, whereas facilities of examination is also available. Now, in practice guideline, it is the doctor who decides whether the telemedicine is appropriate or in-person consultation is required. So, doctor has to decide whether the telemedicine is appropriate or not. At any time during consultation, if doctor feels the need of in-person consultation is must, then he can stop the process and ask the patient to see the doctor personally. Identification of both doctor and patient is must. Doctor should display his identification and registration number on the platform, website, and prescription also. Same way, RMP should also verify the patient's identity by iCards, also verify his age, sex, address. So both the way identification is must. Then the doctor should decide the mode of communication, whether it is audio, video, text, real time, or convenient time. That the doctor should decide. Next. As discussed in length, consent is must. If patient starts the telemedicine process, then the consent is implied. No need to take consent. But if doctor starts the telemedicine consultation, then express consent of the patient is must. In case of minor, the parents' consent should be taken, and in case of incapacitated parents, their son or daughter's consent can be taken. Consent can be even verbal or written. Now, consultation include history, inspection only if it is a video consultation, vital signs in case of health worker or RMP is on the patient side. RMP should see his past records and investigations. After that, the doctor can advise that these are the investigations to be done, and then you can ask for follow-up consultation. At the same time, RMP can give prescription, he can do counseling and health education, and also give advice regarding the follow-up consultation. Next. Now, how to write prescription? This is a standard prescription format published in telemedicine practice guidelines. You can download it and see it, but there are certain rules. There are lists of drugs like O, A, B, X. The list O includes safe medicines, which are usually prescribed over the counters, like paracetamol, ORS, cough lozenges. These are safe drugs. This can be prescribed by a doctor during any mode of consultation. List A drugs. This list includes usually prescribed medicines for which diagnosis is possible only by video consultation, such as skin disease to prescribe skin cream, conjunctivitis to prescribe eye drops. Also, this list includes refill medicines for chronic diseases like diabetes, hypertension, asthma. List B, it includes add-on medicines, adding antihypertensive, adding anti-asthmatic, adding anti-diabetic, adjusting the dose of thyroid hormone. So adding drug for chronic diseases can be given by any mode of consultation. Here, the doctor can choose to have audio, video, text consultations. And last is the prohibited list. Schedule X drugs, narcotics and psychotropic drugs are not to be prescribed on telemedicine platform. Anti-cancer drugs are not to be prescribed on this platform. Even biologics are not to be prescribed on this platform. Next. RMP should be aware of all laws, starting from Indian Medical Council Act 1956, Professional Conduct, Etiquette and Ethics Regulation 2002, Information and Communication Technology Act, Rules 2011, and recently passed Digital Personal Data Protection Act. Because RMP should maintain data privacy and confidentiality of the patient and their illnesses. RMP should not form groups for health education because the patient's data will be revealed. And there are penalties for misconduct. Next. RMP should maintain patient records, reports, documents, audio, video logs, recording, and all necessary recording for a period of 5 years as laid down in Clinical Establishment Act. Doctor can collect fees in the same manner as for in-person consultation, but the receipt should be given. There are guidelines for providers of technology platform, which we'll not discuss here. And there are certain responsibilities of Board of Governors from NMC to regulate these telemedicine practices across India. Next. But there are certain limitations because guidelines do not mention about the specification of platform regarding the softwares and hardwares and what kind of software it is and how it functions. And second issue is interoperability. I may practice telemedicine in a different way. Some other person is practicing telemedicine in a different way. So it is always a bias. And data safety and privacy is an important issue. And mind well, not valid for the patients outside India. You cannot consult patient on telemedicine platform who is staying outside India. And it can never be a substitute for in-person consultation. Next. But future is bright because of unfavorable doctor-patient ratio and patients staying in remote areas, need of telemedicine will increase. There are many new things developing in the internet world. IoT, there is Internet of Things, wearable devices, artificial intelligence, machine learning. They all will increase the scope of telemedicine in India. Estimated market share of telemedicine is likely to jump very high in coming 5 years. Even government's National Digital Health Mission, they are very much favoring telemedicine practices in India in future, because this was eSanjeevani app, which was a app by the Ministry of Health and Family Welfare for telemedicine, which was used widely during the COVID times. But I am seeing mark my words, within the next 5 years, we all will be practicing telemedicine in some or the other way, because it is a need of time and it is the way forward to see, to have an expert opinion. It is the way forward. So if future of telemedicine is right, there are online training sessions also to practice telemedicine. You can search in the Google and it will give you the telemedicine practice session, how to practice telemedicine, and start learning, because if you want to practice for another 5-10 years, this will have to be included in your clinical practice. Thank you. Lastly, my sincere thanks and gratitude to Dr. Kamlesh Saini, Dr. Mehul Shah, and entire IMA GSB and the Dhanya Madam and GNLU. Thank you.
Thank you, Dr. Sanjay Bhatt. I think the recent COVID pandemic have given the little bit idea about the telemedicines, but Dr. Sanjay Bhatt, you have very nicely explaining the telemedicine's guidelines practice. Thank you, Dr. Sanjay Bhatt. Now we are at the end of the sessions. So I would like to invite Dr. Dhiren Mehta for the vote of thanks.
Thank you, Dr. Kamlesh Saini. First of all, I am thankful to GSB IMA for providing such a nice platform and with a very unique idea, particularly Dr. Bharat B. Kakade, President, and Dr. Mehul B. Shah, Secretary. And we are, just for your information, we are just started this webinar, and this is the first program, and we are planning every month one program. So we will try to cover most of the problems affecting our doctor friends. So we will keep always remain in contact with us. In the next month, we will come with another topics by another speakers. We are also thankful to GNLU professors for providing such a very good knowledge to all of us. And they are already told very nicely that ignorance of law, ignorance of knowledge is not an excuse in the language of the law. So all doctors must know the importance of the law in their practice. I am also thankful to all the speakers for giving us such an excellent presentation and justified their topics very nicely. We are also thankful to all the viewers for attending the whole program very nicely, and we will like to wait for the next program in the next month. Okay, thank you so much. Dr. Saini, we will like to conclude now.
Yes, with this, we conclude our today's sessions. Thank you. Thank you all. Good night.
Thank you so much. Thank you.